Safe Food Human Health and Nutrition team. This event is coordinated by Safe Food and the Food Standards Agency in Northern Ireland, and we do so on behalf of the All Ireland Food Poverty Network. During the webinar, you can ask questions via the Q&A box at the bottom of your screen. This will be available throughout the session. Please include the name of the presenter that you would like to address your question to, and we will try to answer as many as possible. For any technical issues, please use the chat box at the bottom of the screen, and please address those questions to panelists only. We, of course, encourage you to tweet about the event, and if doing so, please use the hashtag food poverty. Finally, please note that the event will be recorded and that the recording will be available after the session today. At today's webinar, we will have the opportunity to hear from our speakers on health inequalities and food poverty. But before that, we are very pleased to launch the report, What is the Cost of a Healthy Food Basket in Ireland in 2020? And to do so, we are joined today by Robert Thornton. Robert is the Senior Research and Policy Officer with the Vincentian Partnership for Social Justice. And since joining them in 2010, his work has focused on the expansion of budget standards research in Ireland and its application to policy analysis and development. Robert's research interests include the interaction of social welfare and tax systems, income adequacy, and approaches to measuring poverty and social exclusion. Robert is a graduate of Trinity College Dublin and Queen's University Belfast, and is a founding member of the Irish Living Wage Technical Group. Good morning, Robert.
Morning, thank you. I'll just share my screen. Thanks for that, Joanna. So this morning, I'm going to briefly talk about the latest report in the Cost of a Healthy Food Basket series. This is our fourth report in the series since 2015. The research is carried out by the Vincentian Partnership for Social Justice, and in it we examined the cost of a healthy food basket using the Minimum Essential Standard of Living, or MESSL data. In the reports, we look at 6 household types in the Republic of Ireland living in both urban and rural areas, and we examine food as a proportion of overall minimum living costs. We also look at food as a proportion of income, and we look at 2 scenarios: the households in receipt of social welfare and the households in minimum wage employment. We also produce a complementary series for Northern Ireland, which examines 4 household types. And this morning, I'm going to provide a brief overview of the latest report for 2020 costs, and also highlight some of the key trends from this series of reports. So the Vincentian Partnership's consensual budget standards research identifies the cost of what's required to enable a life with dignity at a minimum but acceptable level, what we call the Minimum Essential Standard of Living. It represents a standard that no one should be expected to live below, and one which meets physical, psychological, and social needs at a minimum but acceptable level. The research works with members of the public in deliberative focus groups, and in these, we have iterative, in-depth discussions, each building on the work of the previous stage to reach a consensus on what people agree is essential. So the research places an emphasis on needs, not wants, and produces comprehensive, transparent, itemized lists of over 2,000 goods and services, detailing what's required for households to have a minimum but socially acceptable standard of living. Then this basket of agreed items is priced, and from that we can produce the average weekly cost. So the MESSL research establishes a direct, evidence-based benchmark of what's required for people to live with dignity, participate in society, and avoid poverty. Here we have the cost of the minimum food basket for 6 household types in 2020. And the cost of the basket, as you can see, varies by household composition, from the 2-parent households with children, or 1-parent households, single adults, and 2 pensioner households. So the minimum food cost for a working age single adult household type are the least expensive, at an average of €51 per week. And food costs rise as children grow older. So the minimum food costs for a 2-parent household with a primary and second level age child are the most expensive, an average of €169 per week. And this emphasizes the additional minimum needs and costs associated with having an older child in the household. In all cases, food comprises a significant proportion of the minimum expenditure need and is amongst the most expensive categories of the MESSL household expenditure needs. Our report also examines the cost of the minimum food basket in the context of household income. And we look at food costs as a proportion of income when dependent on social welfare and when in minimum wage employment. We find that the cost of the minimum food basket represents a significant proportion of household income in all cases. For example, Food costs for the two-parent household composition, which includes an older child, demands the highest proportion of household income. And meeting the cost of the MESL healthy food basket would require over a third of this household type's social welfare income, or over a quarter of household income when in minimum wage employment. So looking then at the trends we found over this course of research, firstly, we see that food is a significant cost for households with an older child. And the cost of feeding a teenager is more than double the cost of feeding a preschool-age child, and almost 1.5 times that of a primary school child. The minimum healthy food costs for a teenager are approximately €50 a week, and in 2020, this equated to over half of the combined child income supports available for a social welfare dependent household for this age group. We also find that the social aspects of food are important, so that this spending on social eating makes up an important part of the food basket for all household types, and accounts for a larger proportion of the basket in single person households. These social and cultural aspects of food are included in the MESL basket to ensure that the minimum standard enables households to participate in activities that are a normal part of everyday life. And the minimum food basket also costs more in a rural area, as rural households need to purchase some perishable items, such as bread and milk, in local shops due to their distance from larger grocery stores, and these stores would have lower prices. Finally, the research has consistently shone a light on the challenge of trying to balance the cost of a healthy food basket in the context of meeting other needs and expenses when on a low income or an adequate income. In reality, many low incomes may sacrifice a healthy diet to try and meet other competing demands. Effectively, they have to choose to do it out in essentials such as healthy food in an attempt to make ends meet. Thank you very much. Thank you.
Thank you, Robert, for this great presentation. And I would like to add that the report is already available on our website. I would also like to note that in partnership with our colleagues at the Food Standards Agency, we launched the cost of a healthy food basket in Northern Ireland in June. And the report is available on both organizations' websites. And I would like to invite all participants today to listen to our podcast on this subject, featuring Robert and his colleague, Dr. Bernadette McMahon. The podcast is available from today on the Safe Food website, as well as Spotify, iTunes, or Google Podcasts. And I will now hand you over to my colleague, Sharon Gilmore, the Head of Standards and Dietary Health at the FSA, who will be chairing today's webinar. Thank you so much.
Okay. Thank you, Joanna. And as Joanna says, I'm Sharon Gilmore, and I head up the Standards and Dietary Health team at the Food Standards Agency in Northern Ireland. And I will very much welcome you to the webinar this morning. Thank you, Robert, for your presentation. And we have 3 further fantastic presenters this morning who, over the next hour and a half, are going to define what we mean by inequalities, the impact they have on food poverty, and how they affect our diet, health, and well-being. Our first presenter, I'm delighted to invite, is McCusker, who is Programme Manager and Healthy City Coordinator at Belfast Healthy Cities. Belfast Healthy Cities is a partnership organisation that has responsibility for implementing the World Health Organization Healthy City requirements in the city of Belfast. As Programme Manager, Anne is leading the development of the Health Literacy Programme and also supports the Health Inequalities and Healthy Ageing Programme. Anne's presentation will explore the need for a common understanding of inequalities to take collective action to mitigate the impact felt by people and communities. So thank you very much, Anne.
Thank you, Sharon, for the introduction. I'll just share my presentation and check that you can see it okay. Yeah.
Perfect.
Great. Thank you. My name is Anne McCusker from Belfast Healthy Cities, and I'm just going to discuss with you this morning the importance of a common understanding of inequalities and taking collective action to mitigate against the consequences of inequalities felt in communities. So Belfast is a member of the WHO European Healthy Cities Network, which consists of 1,400 cities across Europe with a population of 165 million people. You can join the network as a designated city or a member of the national network. Belfast is delighted just recently to have been accepted to phase 7 of the programme, and we've been a member since 1988. We're also, excuse me, a member of the UK National Network and work closely with the Irish cities that are designated Cork, Galway and Waterford. And the programme through the Irish National Network of Healthy Cities and Counties aligns very closely to the delivery of Healthy Ireland. So you can see from the circle on the right, the goals and requirements, the themes for phase 7 that each city interprets and works towards. And the 6 Ps you'll see around the outside of the circle were developed by MERS across Europe to really translate the sustainable development goals into deliverable actions that they could promote public health issues to improve the health and well-being of citizens at city level, at local government level. And health and well-being and inequalities is at the centre of everything we do. The faded picture on the left shows you the 4 ways of working that were developed initially at the inception of the network and are very relevant today, particularly in the work on inequalities, to develop strong partnerships, designing supportive environments, tackling the wider determinants of health. So it's not simply the health service that has an impact on our health, it's everything else in our lives, and creating effective policies that can change the impact, the gap in inequalities, and deliver health and well-being for all. The 5 programmes along the bottom are our programmes that were developed in partnership with our partners across Belfast for phase 7, and very much of inequalities at the core of the delivery of each of those. This just simply shows you our reach and our networks. We work directly with WHO Europe on a number of working groups and with cities individually. And then our board of directors has both Queen's and Ulster University. And we are a voluntary and community sector organisation, and we link in with the public sector and the private sector as well to deliver our programme. So it's very much a partnership approach, and that awareness that it has to be cross-sectoral action to create change. The main challenges being faced in Europe were listed on the screen, and absolutely populations are ageing right across the world. The impact of climate change, environmental challenges, inequalities are affecting people in all cities and towns and rural communities. I suppose when we look now, living through the effect of COVID-19, we can see clearly who was most affected by COVID-19, and it was those people and communities already feeling the effects of inequalities. It was our older populations, and it was people that worked in possibly low-paid jobs. And the choice that some older people had to make before COVID-19 was between heating their home and eating. And that very much, and we can see from Robert's analysis of the food basket and the rising cost of food, that will be a choice that many people will face in the years to come as well. When we talk about inequalities, it's really important to have a clear definition. We use WHO definitions, but I think it's the first point of work that needs, when you're tackling inequalities, if inequalities is an outcome or part of your work that you're looking to do, you have to be really clear on what it is, and that all partners around the table agree and understand that. So it's the unequal distribution of power, income, goods and services, both globally and nationally, and how we see that in our communities, how it shows up is access to healthcare, schools, access to education. It's not simply the availability of services, but how they're provided, and there aren't barriers in place for people engaging and considering working conditions, living conditions to allow people to flourish. And it's taken that collective support. It's not placing the onus on the individual. When we're thinking about inequalities, and I suppose this definition that I have here comes from the landmark publication Closing the Gap in a Generation, which was published by WHO in 2008, but is still very relevant for today. We all also have to consider equity, and a way that Ron Draper described this in his work with Healthy Cities. He said that if you live longer than I do, or if you suffer from less sickness and disability, our health status is unequal. This is inequality between us, but not necessarily inequity. The differences may not result from our living conditions, which may be essentially the same, but from accidents, genetics, or lifestyle choices. If, however, the differences in our health result from different living conditions, mine being less satisfactory than yours, then it's a question of inequity. So it's really important then to get clear on your understanding and definition of inequalities that you're using, and also to consider inequity as well. I think this picture highlights the difference clearly. So inequality is almost a service being provided, the same service for everyone, but it doesn't consider our individual or population groups' needs that would allow them to engage effectively. So from the picture, you can see if we were all given the same bicycle, yes, we have it, there's access to it, but it doesn't consider how we will use it or the benefit. I think that by its existence doesn't mean that it solves the problem. There needs to be a consideration of people's needs within, or it creates that difference. And we can see inequality showing up in our communities. Children from poor families are more likely to be born with a low birth weight, suffer the effects of passive smoking, eat less nutritious food, be less successful at school. And these statements, we look at the data, certainly the most recent data for Northern Ireland, but we also have to understand the story behind the data if we are to work to mitigate the effects of them. And we can see that the effects of these problems accumulate throughout life and have a huge impact on people being able to flourish, being able to succeed, access employment, lead a good quality of life, and ultimately affects their life expectancy, how long they live and how well they live. So the latest information from the Department of Health in Northern Ireland, the Health Inequalities Report, highlights life expectancy. Now, how it's calculated is the 20% most deprived compared to the 20% least deprived, and what is the difference and what is the gap there. So we can see for male life expectancy for 2017 to 19, life expectancy for males in the least deprived areas was 81.6 years compared to 74.7 years. So that's a huge difference of 7 years based, we might just say, on where you live and the circumstances where you live and the opportunities that that presents to you. Similarly, for female life expectancy from 2017 to 19, life expectancy in the least deprived areas was 84.5 years compared to 79.6 years in the most deprived areas. When we look a wee bit closer at that and we consider healthy life expectancy, so not just how long you will live, but how well you will live, we can see the differences are even starker. So in areas for male healthy life expectancy, it means that at age 65, people in the least deprived areas, men in the least deprived areas, will start to feel the effects of long-term conditions or health problems that will affect their quality of life. For males in the most deprived areas, that's 51.6, when they can expect, the data is showing us they can expect to feel the effects of health conditions, living with disability, living with long-term conditions, with chronic pain, and how that'll affect all aspects of their life from 51.6 years. Similarly, for females, It's 51.7 in the most deprived areas and 67.1 for females in the least deprived areas. So huge gaps for men of 13.5 years and for females 15.4 years. So that's when you're thinking in terms of how long you live, but also the quality of life, it does suggest that there's a huge link between where you live and your life expectancy and your quality of life. Similarly, when we consider rising levels of excess weight for children, it's measured in Northern Ireland at primary 1, which is 4 to 5 year olds, and year 8, which is 11, 12 year olds. We can see that the trend is increasing for both the most and least deprived areas, with between 18 and 24% of our 4 and 5 year olds being recorded with excess weight at school in primary 1. And then similarly, the trend is increasing from between 22 to 33% for 11 and 12 year olds. So this is just the hard data. We have to understand what's happening and what's creating this change. And I suppose the greatest potential to reduce inequalities is through addressing the wider determinants of health and the conditions in which people are born, they grow, they live, they work, and they age. So what is it within that that is affecting us so much, that is affecting our choices, our ability to live well? A piece of work that we did a number of years ago, it has been developing for a number of years, initially started out with an analysis of child-friendly places, looking at the availability of child-friendly space in Belfast City Centre particularly, but then developed through consultation with about 7,000 children and parents and teachers to a learning resource for primary school children, Key Stage 2, to introduce the theme of place, how it affects our lives, capturing an analysis of the environment and then identifying change. And children come up with projects, and you can see from the pictures, it wasn't skate parks and swimming pools. It was very much somewhere to grow flowers or vegetables and learn about the food cycle, and get outdoors and green space and access to green space in a safe environment. But we also applied this model to the food environment. We had a really fantastic student with us who was really interested in the food environment, and they did a piece of work with children on the Shankill Road, and they looked at the food plate and messages around 5 a day. And the children in the workshop were very familiar with what was high food or high sugar, high fat food compared to your 5 fruit and veg a day and the importance of that. So at a functional health literacy level, they were aware of the messages and they understood them, but it was the next step of action in that. So I suppose on the Shankill Road, it's an area of high deprivation. People are living on limited budgets. They don't have access maybe to a private car. So their source of food provision, their food environment is on their doorstep where they can walk to. So with the children, we did a walk of the road and we identified food outlets. So there was 1 butcher's, 1 fruit and vegetable shop, Iceland, and about 15 takeaways. So when we compare that to the hard data, which suggests that rising levels of obesity are in areas of deprivation, perhaps that is providing a bit of the story behind why we don't always have a choice, and sometimes our choices are limited to what's there. When we spoke then to Belfast City Council, they are doing a piece of work around mapping the route to school and fast food outlets, and that's something that has been developed further in England. I think there's legislation around that, but it just shows that sometimes our choices can be very limited. When we set out to develop a policy or a piece of work, it's important that we have something to guide us along the way, so that the sentiment in the policy is continued through to implementation. There are a variety of tools, and you can identify one that will keep you on track, that you're familiar with, and that's easy for you to ensure that what you want to achieve, your outcomes, is being delivered through the programs that are in place. So health impact assessment has recently been updated by the Institute of Public Health in Ireland and will be available, and a really useful tool to consider both the data and policy development and review. Health in all policies is an approach that is taken. When we look at the wider determinants of health, it's really important that health is on everyone's agenda, because there's such an impact from housing, from infrastructure. And we see along the bottom the 5 areas that the Health Equity Status Report from WHO suggests. They have evidence that if you work on these 5 areas, you will reduce the gap in inequalities in 5 years. So it's a focus on health services, income security and social protection, living conditions, social and human capital, and employment and working conditions. And the tool on the right is a tool that we developed with organisations across Belfast that we're working on or interested in inequalities. And it's a very simple 1-page tool that guides you through a process of analysing a policy at the start in its development or reviewing it, and similarly a project or a proposal as well. It looks at availability, accessibility, quality, acceptability, affordability, safety and responsiveness to people's needs, and considers, will this target those most in need, or is it for the whole population? And if it's for the whole population, it may not have a desired effect of reducing inequalities. Work from WHO that is looking at farm to fork, this initiative has a number of strands, but it feels that by focusing on a healthy food environment, that makes the healthy choice the easy choice, looking at food labeling so that people can make informed decisions, challenging food waste, looking at research and innovation that will guide the work, and then also promoting it on a global scale. Our most recent programme, Green in the City, which we're currently doing an evidence review on and stakeholder engagement to shape the programme, it's looking at the impact of green space, but within that, the conversations that we've already had are very much linking a green space both to active travel, but also during the last 18 months, people have been at home more and are realizing the importance of green space for growing their own food, but also for health and well-being benefits as well. And then just to finish, I suppose this is from the regional committee that took place in the most recent weeks, in the last 2 weeks. And it's again reiterating that point that we need collective action. We need cross-sectoral work to support health and well-being for all and to reduce inequalities. And similar to the work that Marmat is doing, the Build Back Fair approach in his publication, it's looking at taking collective action. And I feel the first starting point is to understand inequalities, that we're all working towards the same goal, using evidence and data to inform the process, and having tools that can guide you through ensuring that what you intend to do, the outcomes that you set, will be delivered through the programme or the policy. So thank you. That's my presentation today.
Thank you very much, Anne. That was really appreciated, really informative. I would just remind everyone that there is an opportunity to ask questions and answers, and there will be a question and answer session at the end. But thank you so much. I'm just going to go ahead now with our second presenter, if that's okay. And we will have the question and answer session, as I said, at the end. So our second presenter is Martin Caraher, who is the Professor of Food and Health Policy in City, University of London. Martin was a founding member of the London Food Board and was a public health representative on the London 2012 Olympic Food Advisory Board. His publications range from food access and local communities through to work on food taxes, school food, cooking, fast food to food banks, and food poverty. Martin's presentation will explore how rising inequalities have a major impact on food poverty and the ability of households to access and afford a healthy diet. So thank you very much, Martin, and I now invite you for your presentation. Thank you.
Right. Thank you. I'm just going to share a screen. You're just all going to disappear for a moment, so just bear with me. Okay, here we go. Okay. Take a second. Okay, all live. Oh, let's go back to the start. Anne's covered some of the same ground that I was going to cover, so there's some slides I will probably skip over. But I think what's interesting for me is how little has changed in 20 years of work. We're still talking about inequalities, and food poverty became more apparent after the 2008-2012 financial crisis. And there was an opportunity that we might do something about it, and not much has changed, I think, since then. And COVID indeed has brought, as Anne said, many issues to the forefront. It hasn't created them, it's the perfect storm. It's made more apparent what we already knew. I want to start with a premise that and you can read this there, that food banks, this comes from Oliver de Schutter, who was the Special Rapporteur for Food, is now the Special Rapporteur for Food for Poverty at the UN. And he says, for example, food banks are testimony to the failure of public authorities to deliver on an agenda. I want to make this point very early on, and it relates indeed, as Anne pointed out, to the Marmot work, that the solutions to food insecurity and food poverty won't be found solely in community responses, they will be found in government responses. And de Schutter says that food assistance in the form of the right to food security, such as cash transfers, food stamps, vouchers, can be defined in terms of rights. So I think we've got to talk about rights around food insecurity, not about charity. Okay, so I'm the angry old man. I've been talking about food poverty for too long. But if you go back, Yeats was talking about it in 1892. And this is from the Countess Kathleen, his play, it's not a poem. And he said it's time that poverty should bolt the door. And he was really writing about the aftermath of the famine in Ireland. And if we knew how to find the deserving poor, we'd do our share. We know the evils of mere charity, because charity does come with some negative implications as well. It's necessary, but it's not a solution to food insecurity. I think we've got to be clear about food insecurity. For some groups, it's not a permanent position. What we know is that people move in and out of food insecurity. So depending on the time of the month, they may rely on family and other networks to source food. They may have a paycheck at the beginning of the month, and towards the end of the month, they move into food insecurity. And that may even be seasonal. So one of the problems we have with the measure is it tends to measure at points in time rather than be predictive of what's happening. And I've put on the chat, one of the other problems with a lot of food security is we tend to measure the bottom 10 to 20%, but there's another 20% above that whose diets are unhealthy and who move probably in and out of a food insecurity or a food poverty issue from time to time. We know pre-COVID that people relied on credit cards to tide them from one end of the month to the other. We've been doing some work here in the UK and in Northern Ireland with my colleague Sinead at the University of Ulster, Sinead Fury, about the loans that have happened during the COVID crisis. People have gone into massive debt, people on low incomes. Household debt has increased among the bottom 10%. So people are borrowing to pay for food and for other essential items. This is the global picture, just to put it in context. You know, this is where the real food insecurities come about due to COVID. I mean, our food insecurity is slightly different in the global north. So here we're talking about the big link with food insecurity is now hunger and obesity. The root causes of hunger and obesity are basically the same, yet we have separate policies dealing with obesity and separate policies dealing with food insecurity. If you look at the root causes, pretty much the same. So we don't have joint budgets. This is the Global Food Insecurity Index, which I was really shocked that Ireland is the best, #2 in the world for dealing with food insecurity. Now, I'm sure many of you working in the area, I'm astounded by this, but go and look at it. It's on the website there, I'm giving you the link to the website. But it's based on affordability and availability. And you saw from some of the results this morning that the rural areas have bigger problems with food insecurity and access. When I worked in the west of Ireland, this was a major problem back in the late 70s, early 80s. Access to food and availability of food is a major problem. But it's worth if you define affordability and availability, Ireland comes out pretty well on a global index of food insecurity. But the figures say nearly 700,000 people in Ireland are in poverty, not food in poverty, of which over 200,000 are children. 111,000 people living in poverty are in employment. So it's not just those who are on benefits. The working poor are the largest rising group of food insecure people. And that's because of pressures on wages, etc., etc. The number of over 65s in poverty has risen by 20,000 since 2008. So that's currently around 80,000. Sorry, I see a typo there. And the rate of poverty went from 8.7 to 11% for this group. There are about 36,000 people more people living in poverty in Ireland today compared to 2008, pre the global recession. Without social welfare payments, 40% of Ireland's population would be living in poverty, not the current formal official figure of 14%. Now, this just shows how important welfare payments and the role of the state is. It can help lift people out of poverty. And there's a clear overlap between general poverty and food insecurity there. And this is a deeply unequal distribution of income. But the problem is inequality is often measured on income, but people have insecure and inconsistent link to working conditions. If you think about 0-hour contracts, think about what New Zealand have done. They've banned 0-hour contracts on the basis that it's bad for family life, it's bad for nutrition. So they've introduced a social policy which has impacts on food insecurity. For Ireland, there's been a narrowing of income, partially helped by social welfare programs. So that needs to be kept in mind with the current budget that's coming up in the next 2 weeks in Ireland. What's hidden within this is wealth inequality. The people at the top of the income scale also have huge amounts of wealth, which isn't income, and they have ways of hiding that wealth. So the disparities in income are even greater when we take into account the disparities in wealth. I saw something on the Irish papers about the number of billionaires in Ireland has gone up. People hide their wealth. The living wage is not necessarily built on the price, availability, cost and access of food regionally. You know, we need to think about what's it like in rural Leitrim or Roscommon accessing food as opposed to Dublin. It's a very different scenario and situation. So what happened, this is data from Northern Ireland that we've used in the past. Households up to between 2008 and 2015 traded down by going to cheaper products. So essentially they went to the Aldi's and Lidl's and the own brand products. While trading down to cheaper products, many people offset some of the food price rises, but the lowest income decile also bought less food rather than trading down. Now, you might say that's good for obesity, but it has nutrient implications. Energy content of these households fell by 8.7% between 2007 and 2010. With growing kids, that's a major problem. You know, it's not just about obesity here. And falling income and static welfare benefits after housing costs, and I'm really talking about, this is our data from Northern Ireland, produce a double effect, reducing food affordability by 20% for the lowest income deciles. Our estimates at the time were that 5% increase in food prices has a disproportionate effect on the lowest decile, up to 20% of their income. Now, the current predictions for the next 9 months are a 5 to 7% increase in food prices on the island of Ireland. So that will have a disproportionate impact on low-income groups. I'm going to skip that. So this is, this is just highlighting the issue. This is some previous research from Food on a Low Income from Safe Food. People manage pretty well. Households and families manage. We might argue with their nutrition and the way they manage it, but they're managing a budget and balancing it against other things. So people buy pizza from Iceland, they're only £1, I get a load of them, they keep all week. You work out your Monday to Friday list before going shopping, you buy according to the list. I don't go to big supermarkets because the temptations are too great. This is how people are managing. So people are exhibiting good domestic economy, but with a consequence for nutrition and food insecurity. Again, this is previously, this is some work that Sinead done for our book on food insecurity, and we took the cost of a emergency food basket and for a pensioner, and we've done it for other groups, but this is the example I'm using here is for pensioner, living alone on £57 a week to a food bank's lowest price £1 food basket. So we took a food basket from a food bank, we costed that and would have cost £17.66. If you wanted them to have an appropriate diet, that would cost £56. So there was a disproportionate impact between what people were getting through food banks and what we might expect them to live on if they had to pay for it themselves. And this is also about social and cultural impacts. Okay, so the pandemic has exposed many of the flaws with the current food and welfare systems, you know, the perfect storm, the problems with transport of food. I was amused in the early stages of Brexit when there was a hummus shortage in Dublin, the great hummus shortage of 2019, because they come from two factories basically here in London. The pandemic is not the cause of these flaws, but merely exposes them to a storm of events. There are differences from the 2008 recession, where poverty was probably wider in its impact. Some of the social impacts have been muted because of keeping people at home. The middle income groups have not suffered, but those on insecure employment and 0-hour contracts are more likely to have suffered and built up debts and suffered food insecurity over the period of the pandemic crisis. So a loss of security of employment, the loss of family and community networks. You know, if you were out of job, your family was more likely, your extended network was more likely, so you were getting less support there. The use of doorstep loans and increased food costs. The use of doorstep and illegal loan lending has gone up massively. People are taking out loans to pay off loans, often at rates of 150% payback. And this has an impact on food. My colleague Liz Dowler used to say that food is the elastic item in the budget. You can compromise on food, but you can't compromise on other outgoings. And a key factor, I mean, Anne talked about it in her presentation. In talking about food poverty, it's inequality itself has an impact on food poverty. The norm at work is that inequality itself is an influence on health outcomes, and Richard Wilkinson has shown that as well. So it's hard to get your head around that, but inequality itself, the social impact of inequality has an impact on our health status. Whether you live in Liverpool, you know, where life expectancy is 12 years less than average life expectancy in London. So these are some of the responses we've seen during the crisis on the island of Ireland. You know, 1 in 5 Irish children go to bed, or this has to stop. Tackling food poverty in Northern Ireland, the New York Times there is about what happens of food poverty as an abject failure of governance. Now, I mean, these highlight what I've just said. And then at the same time, we have strange alliances happening when McDonald's to strengthen ties with Irish food charity. This is pretty worrying from a public health perspective. If any of you are familiar with Andy Fisher's work from the US, he documents the problems with this of linking with essentially unhealthy food providers. So what we've seen in COVID is these are Northern Ireland, we've seen a 5-fold increase in the numbers seeking help from charities. Because they've nowhere else to go. Their family networks have broken down, the community networks have fallen. So they're turned to charities. And due to credit facilities being closed, family and community networks are compromised, and insecure employment has brought about a massive impact on people and how they're coping around food. For low income groups, 1 income or paycheck away from destitution before COVID. COVID wiped out any savings they had. In the first round of COVID, many of the banks shut down credit facilities for low-income groups, so they're using credit cards to tide them over from one period of the month to the other. That as a source of management was shut down for many. They used up their savings. As I said, community and family networks were likely to be compromised. Overall savings have increased across the population, but indebtedness has risen among low-income households. Loans up to 49, but often up to 150% interest in debts. It's been called financial toxicity in primary care. We now have GP practices screening for financial toxicity. And as I said, food's the elastic item in the budget. And as I said earlier on, the indicators of food insecurity and food poverty are obesity and hunger. Yet we have them as separate issues and separate policy areas. They need to be joined together. We need to have health and all policies. So the tensions, hunger and obesity coexist, often in the same groups. They're not necessarily in different groups. You go hungry at one point of the month, and then you overcompromise at others by eating at a point of the month when you have some money by eating energy-dense food. Children are adversely affected by poor nutrition, learning outcomes, education, future health status. Different budgets, but same root cause. So we get inequalities from that. Social life is impacted. I mean, Anne highlighted this in her presentation. Families are making tough decisions. Good household management, but with poor health outcomes. Eat, cook, or heat. And food poverty is often hidden. It's a stigma. I mean, measuring food insecurity, people will often, we know from the US data that people often minimize their situation because actually going hungry is a stigma in the society we live in. And, you know, this issue, Anne mentioned it, of heat or eat, what's going to happen? Energy budgets are going to go up by maybe 5 to 10% in the next 9 months. If here in London, we have queues outside all of our petrol stations at the moment, back to 1979. So Michael Marmot, again, Anne mentioned Michael Marmot, when a society is flourishing, health tends to flourish. When the society has large social economic inequalities, there are large inequalities in health. The health of the population is not just a matter of how the health service is funded. It's more than that. Health is closely linked to conditions which people are born, grow, live, work, and age. And of course, food is clearly important. And the damage, he says that the damage to the nation's health need not have happened. This is his 10-year follow-on to the Marmot inquiry on social determinants, which came out in 2020. We in the UK and Northern Ireland, we need not have seen this damage to health if we'd had some relevant policy. Okay, so solutions. One place to look for is Scotland, so the Dignity Report, and they're saying that charity does not deal with food poverty, it tackles some of the issues of immediate want. It's not dignified and we still have a welfare state. So in Scotland, what they're doing is they're building up a right to food bill. And they're saying that the measure for success will be no increase in charity provision, but people having either a living wage or an income or adequate welfare to live on, that they can afford a healthy diet. So this has become part of a whole debate in Scotland, and COVID has slightly pushed it to the back because of the crisis, but it is an emerging debate. Okay, I'm going to finish on this slide and we'll skip the rest because Anne sort of covered them. Post-pandemic responses, look to formalizing welfare, move away from charity, or integrate charity responses within state responses. It happens in Brazil. It's not impossible to do. Food charity does not in most cases provide appropriate food, adequate nutrition, or tackle food poverty. It tackles an immediate issue of want and hunger, but doesn't address the underlying causes, nor can it. So we shouldn't blame it for that, but we need more structural responses. Think of rights, not charity, and think of food justice, maybe through the food networks. You know, some of the ones that Anne already highlighted sprung up all over the country. Safe Foods 13 community food initiatives, social supermarkets in Northern Ireland, transition towns, eco towns. There's a whole movement out there. Not completely focused on food insecurity, maybe focused on eco nutrition, but there's huge networks to build on there. The EU Child Guarantee. So Ireland is now looking to provide meals to all children in schools. Funding will be following this EU policy, probably FEAD policy, the structural funding at EU level, which has to be matched by governments. But it's worth thinking about the child guarantee, working poor formalized rights and work situations. I mean, 0-hour contracts, we know, are a disaster for both family life and nutrition, because you cannot plan your life. You don't know where money's going to come from next week. You don't know if you're going to have work next week. So you cannot plan your family. And it's just bad for social life. The upcoming budget, the Taoiseach has said there will be tax measures aimed at middle-income people in particular. Why middle-income people? I mean, middle-income people are suffering, but in terms of food insecurity, they're probably not the priority issue, as well as welfare packages to offset the impact of the rise of the cost of living. Personally, I'm more interested in that from the point of food insecurity. Okay, I'll finish on this. This is one of my favorite quotes. Hayley Squires, who was the mother in I, Daniel Blake, says, she was interviewed and she says, why are you talking about food banks existing if you don't talk about why they exist? So why does hunger, why does food security exist in our community? Okay, I'll finish on that and happy to take any questions later on.
Thank you so much. Yeah, thank you. Thank you so much, Martin. That was a really informative presentation. Thank you, and we look forward to questions. I'll just move on because I see the time's moving on. Our final presenter this morning is Katie Hunter, who is a specialist public health dietitian based within the Belfast Health and Social Care Trust, where she leads a team of dietitians working with public health. She is a member of the Public Health Dietitians Group, who use evidence-based interventions to help people facing food insecurity to shop wisely, cook healthily, and make the most of food parcels. Katie also sits on the British Dietetic Association Northern Ireland Board, where she represents dietitians working within public health. Katie's presentation will explore how health inequalities and food poverty can affect diet, health, and well-being, and the important role that dietitians are playing to reduce the impact within our communities. So thank you very much, Katie, and you're very welcome to join us now.
Martin, could I just ask you to stop sharing your screen there, please? Okay, I think Martin might have stepped away. 2 seconds and I'll see, can I take control? There you go. Perfect. Katie, off you go.
Is that okay now?
Perfect, yeah.
Okay. I'm trying to start my video, but it's saying that the host has stopped me being allowed to start my video. So that's maybe something I can't. There we go. Hello. Okay, so thank you very much for inviting me along to speak this morning. And as Sharon has said, I am speaking on behalf of the British Dietetic Association, the Northern Ireland Board this morning. And just to generally talk about the impact of a nutritionally poor diet on our health and our well-being caused by food poverty or food insecurity. So I thought I would just start off just by covering what is a registered dietitian. I know there are many, a mixture of professionals, some dietitians, but just to highlight a registered dietitian. And as you can see, we're qualified regulated health professionals. We work at both the individual and a wider public health level. And I, as Sharon has said, I work at the public health level. And I suppose the crux of our profession is really that we take the scientific evidence and research and we try to put it into something that is more meaningful for people so that they can then have the ability to make changes within their lifestyle and to improve their health and their well-being. And I suppose food poverty or food insecurity is something that as a profession or as allied health professionals is something that we are definitely seeing more frequently and within a variety of settings. So speaking from the Northern Irish point of view, we are seeing it across different settings. So when I say clinical setting, I'm meaning individuals who might be in hospital or in an outpatient clinic, and the dietitian is seeing them when they are going to provide treatment. And most dietetic consultations will include quite a detailed diet history if possible, and that's either with the individual or the family. And it's at this point where it can become obvious that a person might be living with food insecurity, and that could be either a case of they live rurally and they don't have good access to food, or it could be a case of they actually don't have a regular access to food for financial reasons, a wide range of reasons. And this can become obvious from either somebody giving a detailed history of what they have been eating, or it could actually be that within that setting of speaking to a dietitian, you're in maybe a clinical room and there's nobody else there, and somebody might actually just admit and say, currently I'm in a situation where I don't have access to food, or my family we're using food banks. And as Martin had said, there's a stigma associated with it. It is embarrassing for some individuals, and so sometimes that speaking with a stranger as such can be the time that somebody opens about that. Community setting, again, it can be within an outpatient clinic. It could also be within somebody's home. So a dietitian going in to provide treatment within somebody's home, again, somebody can disclose it, or it might become apparent that they live very rurally, or that they live with disabilities that might prevent them from being able to regularly access food. And then finally, public health setting, which is the setting that I work within, and we are regularly working with community groups within communities, within different regionally, within different parts of Northern Ireland. And I suppose we're on the ground and we are seeing how this really is highly prevalent, and the implications that it is having both at an individual level and then also on a population level. So thinking in terms of, well, how does this impact our diet? So I think it would have been a missed opportunity as a dietitian not to show the Eat Well guide in a presentation or in the south of the food pyramid. But I've included this just to highlight that for us, this is what we generally see a healthy, balanced diet looking like. You can see the different food groups. You can see we've got lots of different fruit and vegetables. You can see the sources of the dairy alternative foods, protein sources. Within our carbohydrate sources, we've got a focus on fibre and whole meal. And you can see we've got our essential fats as well, and our fluid. This is what we see as being a good, healthy, balanced diet. But if we think in terms of those who are living with food insecurity or who are reliant on food banks, this is not necessarily the picture that we are looking at. And I'm sure many are familiar with the photographs that certainly during the first few lockdowns that the media were full of photographs of the contents of people's food parcels and what people were receiving and the outrage that it caused, and they certainly did not look like this. Research is showing in terms of what food bank parcels typically consist of are tinned foods. We've got soups, pulses, beans, meats and fish. Sometimes we then have the likes of the sugar, jam, cereals, porridge, things like that. And what is in a food parcel, as we all know, it's very much dependent on what is available, what stock is available. Those volunteers are putting them together based on what is either donated from organisations, or what shoppers are leaving in that basket as you leave the supermarket. There's generally a lack of guidance on the contents, and so it's just generally what people think should be in there or what they have at hand. And there's a difficulty in adding those perishable items. If you think of some of the dairy and alternatives or the protein sources, there's a difficulty adding those in, and that's either due to storage and transport issues with the food bank themselves, or the people who are actually accessing it, they might not have appropriate storage for these items. we obviously are aware of this, but I suppose when I looked at the evidence and the research around it, I came across a paper that had looked at the nutritional content of a food parcel from Trussell Trust. So this was based within England, and generally what they found was that they were meeting the energy requirements for an adult. In fact, it was exceeding the energy requirements. But as you can see, it was actually the sugar and carbohydrate content was way, way higher. So instead of us getting those calories and that energy from good, high fiber sources of carbohydrate, we were getting them from very energy dense foods. Also, the total fat provision you can see was down. So again, we're not getting those nice healthy fats that we do need. And then that means in terms of our absorption of our fat soluble vitamins such as vitamin A and D, that wasn't there. So the vitamin A and D content of our food parcel contents were lower. And just generally, I think it had been touched on in one of the previous presentations, people seek calorie dense foods. If they're on a low budget, they are seeking something that they know is going to make them feel full, and it tends to be cheaper, highly processed, calorie dense foods. And that's not something that, as you can see, is recommended in terms of a healthy, balanced diet. In general, one of the most obvious implications of food poverty, or certainly living with extreme food insecurity, is malnutrition. And you can see around in terms of this diagram, this is showing you some of the implications of malnutrition. And malnutrition essentially is when you don't get the correct amount of nutrients from your diet. So we often think of somebody who is malnourished, and we are thinking of an elderly person who is very frail and isolated. But actually, if you think of the definition, when we don't get the correct amount of nutrients in our diet, that could be a child or an adult who is classified as morbidly obese. They're not getting the correct amount of nutrients. And you can see the implications of malnutrition are wide-ranging, but really do reduce the quality of life. The British Dietetic Association guidance in terms of somebody who's living with malnourishment, you can see, I've just included here, we've got our portions of cheese, milk, yogurt or alternatives, our oily fish, 2 portions a week, fluid, some milky drinks. And you can see, if we think back to what was in a typical content of a food parcel, that just is not necessarily something that people are getting. So if somebody is already suffering from malnutrition, they are not likely to be able to access these easily. Generally, the research is showing that there are 3 themes in terms of the impact that living with food insecurity has on our health. And obviously, food insecurity is a continuum. It could be that somebody just doesn't have the best access to food. They maybe only have one local shop and it's not that close. Or it could actually be that somebody is struggling to access food completely, no matter how far they were to travel. So the 3 things: increased risk of developing chronic conditions, difficulty managing existing conditions, and then impaired efficacy of medications. So if we think in terms of the increased risk of the conditions, for adults, iron deficiency, anemia, and if you think of some of the sources of iron that we get, some of our meat products, our red meat, some of our vegetable sources, if they're not there, you can see how iron deficiency anemia would be a pretty common one. Diabetes, cardiovascular disease, some types of cancer, and depression. And depression is one that both if you are living with food insecurity, you're more likely to get, and then if you have depression, you are more likely to suffer food insecurity. So there's an interesting relationship with that. And then with children, again, iron deficiency anemia, research is suggesting that those children who live in food poverty, they're more likely to have asthma, poor oral health. If we think of some of the foods that we are eating that we can get that are cheap, that are easy to access, don't require a lot of fuel to cook, can really start to have an impact on our oral health, depression and anxiety, and also birth defects as well. Moving on to managing existing health conditions. So as I mentioned earlier, those who have health conditions are at an increased risk of food insecurity themselves, and research is showing that they are the highest users of food banks within the UK. And if we think of some health conditions such as diabetes, it could be celiac disease, COPD, food banks, we've touched on that they are literally providing what they have. They don't necessarily have a regular supply of certain types of food. They largely are just unable to provide the type of food that's required, the quantity that somebody might need, or the quality. So in order for somebody to manage a chronic condition that is dietary related, this can just become impossible. And this diagram that I've put in, Seligman and Berkowitz had kind of proposed that actually not only does restricted access to food make it difficult for us to manage our health conditions, but it is that increased anxiety and stress around not having a regular access to food that makes it even more difficult to manage our health conditions. And so ultimately, we end up with poor condition management, even if somebody had the best intentions or knew exactly what it was that they were meant to be having. It's just out of their hands. So as I said, I mentioned COPD as one of the examples, and I've just focused on two just for this presentation, but COPD, it's a respiratory disease, and there are high metabolic demands. So people who are living with COPD have very high calorie requirements. And often they can experience physical weakness and a loss of appetite, a loss of interest in preparing anything to eat, but yet they need the calories in order to manage their condition. So it can result in difficulty preparing meals. And for some, just that requirement of maybe a reliance on slightly more convenient food or a reliance on good quality, nutritious food, the expense is just too high, and ultimately that ends up with poor condition management for them. And diabetes, and this is one that you can possibly really see very clearly the impact of food insecurity. Diabetes, type 2 diabetes, can often be managed by diet alone, and generally it can be managed by just following loosely that Eat Well guide, the diet that it's showing there. However, what research is showing that diabetics who are facing food insecurity, they are typically eating less fruit, vegetables, and protein, and they're eating more of those high energy dense foods than those who aren't. And so the main aim of managing diabetes by diet is that you're trying to keep your blood sugars very level, and you're trying to keep those very consistent. If you have long periods where your blood sugars are very high and you're not able to manage those, then that is where it results in complications. And I've put it here just in a diagram so that it can be clearly seen. So if you think, if somebody has a restricted access to food, then it results in they're trying to manage their diabetes by just following their diet alone and being mindful of what they're eating, but they don't have the access to that general healthy balanced diet. It means that ultimately they'll go to an appointment and a decision will be made that their blood sugars are not being able to be kept regular or stable, and so they're at risk of complications and they're going to have to start medication. The difficulty with medication for diabetes is that it is often precisely worked out based on how much carbohydrate somebody is going to eat, the types of food somebody's going to eat, when they are going to eat. And those living with food insecurity, it just cannot be predicted in that way. It's not a set pattern. And so that really causes the difficulty in terms of taking medication. And when we're taking medication for diabetes and we're not actually having the food to go alongside it, that puts an even greater risk in terms of complication. And you can see poorly controlled diabetes, it ultimately ends up with the complications such as hypertension, kidney failure, retinopathy, and amputation, and ultimately poor condition management. And again, as I said previously, that might not be because the person just didn't want to follow the guidance or follow the care plan that had been given. It is without it's out of their control. And then finally, the impaired efficacy and the safety of medication. And I've touched on this now in terms of thinking of how we would be treating diabetes when there is medication involved. And we are all used to different medications saying we need to take it with food, we need to take it before food, we need to take it after food. And generally, the reason why that is there is because it promotes the absorption or the effectiveness of it, but also it is to try and prevent unwanted side effects. So it can irritate our stomach and generally unpleasant side effects, maybe indigestion with certain medication. But if we think about it, if we have restricted or unstable access to food, then we're left with some choices. And ultimately what the research is showing is that people who are living with food insecurity of whatever scale and they have to take medication, they're generally taking different options. One is that they might take the medication and they're taking it without food, and they are just going through the unpleasant side effects and the possibility that it's not being absorbed in the correct way, and they're just taking it anyway and living with those side effects. Others are perhaps deciding, well, actually, I need to take this 3 times a day. I know I'm not going to be able to eat 3 times a day, so I'm going to skip a dose. And you can see how ultimately that really does have quite a significant impact on how somebody is managing a health condition. Some get to the point where they just don't take the medication at all, and ultimately that is resulting in poor condition management. When I looked at some of the research in terms of what people were saying in terms of the impact of their health and well-being, I found a study, and that was from the northeast of Scotland. And basically, it was a small study, but it talked in in-depth interviews with 20 people who were regular users of food banks and lived with health conditions. And you can see that generally what they were saying is that they had little to no control. They didn't know what they would be eating, when they would be eating it, where. So ultimately, eating, instead of being something that we do for pleasure or with other people, it just was a negative experience. It provided no enjoyment whatsoever. And that ultimately had a significant effect on mental health, which itself then had an effect on the ability to manage their condition. You can see other bills were paid first. They generally maybe lived off tea and coffee because that was something that was regular that they could have. Few ate the typical 3 meals a day. As we had discussed, they cut back on medication. Generally, and this is obviously a very common thing that people would say, is that they prioritize other people's food needs before themselves. So possibly parents or guardians in some way are prioritizing children or people that they're caring for. They're buying cheap, easy meals that you can cook quickly and that are calorie dense. And then they're either skipping meals, or in the times that they have access to food, because as we touched on earlier, it could be that somebody just has infrequent access. So during that period where they do, they are hoarding the food. And so they're not eating just at a leisurely pace. They're hoarding it because they literally do not know when they'll next get something to eat. And I just want to finish off just with looking at in terms of, well, what dietitians, what are we doing in terms of reducing the impact? We're aware that this is more prevalent. We're aware that this is becoming a healthcare issue. It's not just an individual issue or issue with families. This is a healthcare issue. And ultimately, what are we doing? So as Sharon had touched out, I work within a regional group called the Public Health Dietitians Group, and we are based across the 5 trusts, and it's a mixture of dietitians, nutritionists and dietetic support workers. And you can see that some of the things we've been doing We would signpost to other services, food banks, charities, community groups, connect to community care as a service within the Belfast area, and that can put individuals and families in connection with other services. We run nutrition education programs within the community. We train people within the community, and you can see that some of the things they focus on: food preparation and cooking, food storage, meal plans, budgeting, shopping lists, all that can provide significant help. We've developed a recipe book for those who are using food banks. I mean, you can see it covers cooking techniques, fuel saving tips, and then it also has recipes which aren't necessarily focused on being the healthiest, but they are realistic with what people are getting. In response to a need during the pandemic, we developed guidance for food banks and those who were providing emergency food parcels, and this suggested items to include, give information in terms of health conditions, how to make food parcels stretch a bit further and to make the most out of them. We've also developed videos, so cooking videos, cooking demonstrations for people to watch free online. We've ran free webinars, social media posts, all to try and make information and guidance more accessible to people. And just finally, in terms of recommendations, and this has been touched on, but from a British Dietetic Association perspective, really our recommendations would be for a food strategy for Northern Ireland, and that food strategy would be one that would be across departments. It would be co-owned, co-produced, and it would basically take into account the wider impact that all those different policies can have on somebody's ability to access nutritious, good food, and it would recognise the importance of good nutrition and hydration. And in terms of food sovereignty, just that again, people have a right to access food, and the right to food, it was touched on in a previous presentation, but the right to food has been introduced in Scotland, but that's something for Northern Ireland. And again, it's that it would be a legal right, that it would be for all in Northern Ireland to be able to access food and not reliant on food banks. So thank you very much for giving me the opportunity to speak this morning, and I'll hand back over to Sharon.
Thank you very much, Katie. Thank you. That was really informative, and thank you very much. I'm aware just the presentations have been really, really useful this morning. Lots of information, really informative, and we're receiving a lot of good feedback. So thank you very much to both Robert and Martin and Katie for your time this morning and the level of the level of details. We do have a number of questions that come in. I'm just aware we are running short on time for the questions. But maybe if I could just lift a number and ask sort of individually, but a closing question that I would like sort of all presenters to finish on, which is one that has come into the chat, would be useful, is what is the top action to address food insecurity in children on the island here as such? So if all our presenters could maybe think of what they would like to say on that, what would one of your top actions be to address food insecurity in children? But first of all, one of the questions that's come in this morning is, if it's okay, Anne, if I could ask you a question, how have the different phases of the World Health Organization European Healthy City Network progressed phase on phase? Are there major differences in phase 1, say, to phase 7?
Well, I suppose they're informed by WHO, the priorities that are coming through the European office and its emerging public health issues. Belfast has been a member since 1988, so right from the start. The four guides that I put up at the top are still very relevant, so the way in which we work, but absolutely the themes have changed. One of the initial ways of working, one of the initial themes was cross-sectoral work, which is now quite commonplace and a way of approaching the wider determinants of health, but even having the wider determinants of health on the agenda. In some instances, it's commonplace. I suppose we can see the links between infrastructure and health, and the other departments on health and policy right across. But as Katie has suggested, like a whole of government approach is needed. So while some ways of working, like intersectoral working, are commonplace, there is a way to go on other things. A thing that we've been working on probably for the last 15 years or so is healthy urban environments, which has changed into healthy places, which has looked specifically at child-friendly and age-friendly cities and towns. So naturally, some themes will progress and develop. And almost our work is to get it on the agenda and then pass it over when it is. So the work on age-friendly cities is now delivered through Belfast City Council, and a really vibrant network across Northern Ireland. And that's a theme, you know, worldwide the WHO promotes. So they have changed, but inequalities is still at the core. I think, as Martin said, Yates was talking about it. So it's something that there are some issues that we will still continue to talk about and work towards. So, but they change every 5 years, and it's up to individual cities to interpret them with their partners, what's on the agenda for them, new projects, and also to continue where the work is needed.
Okay, thank you. Thank you very much, Anne. Martin, could I, another question that has come in, which we've been saying for years, we need to move away from food banks as a source of support. What do you think is the reason that this hasn't changed? That's a big question.
Because it's easy for government. I mean, they can just hand the issue to the charity sector, and in many ways it saves them money. They don't have to pay out through welfare for food because they can send people to the food bank. And we know what's happening in England and Northern Ireland and Scotland is welfare services are measured on how much money they spend. So if I go into a welfare service, they used to give me money to go to buy food. Now they send me to the food bank, so I don't have to. So their KPI is to save money. I mean, the industry have got in bed with food banks. I see Tara is online there, Tara Kenny from Cork. Talk to Tara about this. Read Andy Fish's book. I mean, there's an unholy alliance between the food industry and food surplus and food redistribution, because they're not having to pay to compost or bury the food. They're sending it to the food banks. I mean, it's complicated, but it's Tara's figures are saying that it's set to grow in the next 5 years on the amount of food donated, because they can take it off the shelves and don't have to put it into landfill and don't have to pay for landfill. I mean, that's why they're doing it. That's why the food industry are doing it. And that's not to demean individual food banks. The problem is this is a food banking issue, not a food bank issue. I mean, the charity provision is probably always going to be there, but we need to stop its growth. That's the problem. It's not a solution to food insecurity or food poverty.
Yeah. Martin, that sits quite nicely with a further question, you know, and this is maybe for other panelists as well. You know, what roles and responsibilities do businesses have? Martin, would you like to maybe start that one, just to follow on from your previous answer?
Pay people a decent wage, do away with 0-hour contracts, give them guaranteed hours of work so people can plan from week to week. We heard about the problem of people not being able to plan for their food provision next week. So, I mean, this has actually got very little to do directly with food, but everything to do with food. It's in it's in employment conditions for people, essentially. And government need to keep an eye on welfare. What's clear particularly from the south of Ireland is that welfare has massively cut down on poverty. And that can't be lost sight of in the current round post-COVID of people tightening belts, including government. We need to keep welfare payments up at a minimum level.
Yeah. Katie, what about, would you have any views on the roles and responsibilities of businesses, food businesses?
I think they have a great responsibility to make things more accessible for people. When, you know, we're talking about that people are reliant on food banks and that they should be eating this and they should be eating that in terms of a nutritious thing, but then they go into a supermarket and the first thing that is facing them is you know, a wall of cheap processed foods, and that's what's cheaper for them. We need to make it more accessible for people to actually, and not just a kind of a novelty, here's a free banana for your child whilst you push them around the supermarket, something that actually is able to empower them to make change.
Okay, yes, you're right. Okay, Katie, thank you very much. I'm just trying to, there was another interesting question. They're all interesting questions, but how difficult is it to make meals out of a food parcel? Katie, I know maybe a question was directed to you, but Martin may have would like to answer that one as well.
I mean, I'll speak right before Martin. But yeah, I mean, none of us really now are used to making a meal out of tinned produce, and we have done work in the past where we've gone into community groups and we have said, okay, we're going to make this today, we're going to make a cottage pie, and we've lifted out the ingredients, and it has been tinned mince, it has been tinned potatoes, and people are almost repulsed by the fact that that is what we're having. But in fact, it's reality that some people might not have the skills, might not have the equipment to be able to make the things, but then actually at the end of it, they're quite surprised that it is a nutritious meal. So I do think that firstly, it's a stigma. And secondly, a lot of the time, if we are getting tinned produce, it's a case of people don't necessarily know what to do with the items that they have got. And that's what led to members of my team developing a recipe book, because it was to try and provide some sort of guidance to people who found themselves in a situation where they didn't have choice over what to make, and they were making the best of what they had.
Okay, thank you. And Martin, have you any views on how to make meals out of food parcels?
Difficult. I mean, the problem is consistency. What you get from week to week depends what's in the food parcel. So, you know, it's not necessarily basic essentials. And it because of the nature of many food banks, it tends to be tinned and ultra processed food. It's not necessarily fresh food. So sometimes compiling a meal out of it is next to impossible. I've given a link in the chat to some work I've done with a colleague in Liverpool, Robbie Davison, who runs an alternative type charity. And the problem is consistency. I mean, Katie pointed it out, you know, what comes in the food bank parcel from week to week varies depending on what's donated, either through local donations in the supermarket or surplus food from the supermarket. So you might get loads of tinned something this week and then not anything for the next 8 weeks, but you might not get onions in the parcel.
Yeah, no, thank you.
But we need to keep in mind that people's facilities to cook are also compromised here. You know, it's people, it's the eat or heat phenomena that people get something that's why people go for easy options of heating up ultra processed food, the energy dense food, because you can put it in the ping generation, you can put it in the microwave, but you're not using energy because you can't afford to use energy because you have to pay bills.
Yeah, no problem. Could I maybe, I'm just aware of the time, we're approaching nearly the end. Could I ask, really one of the questions came in from an official, what is the top action that you would suggest to address food insecurity in children? And could I maybe start with yourself, if that's okay?
I'm thinking about the work that we are doing around healthy places and green in the city, and it's speaking with organisations that are involved. And one of the I suppose asks that's coming from the community is space to grow your own. Now, it's about engaging people in decisions that will affect their local area and community, and providing them with the space to create change. That doesn't link into the provision of nutritious meals for children when we looked at holiday poverty when children are out of school, but it is a way of creating change in the community and growing your own building capacity as well.
Okay, thank you, Jan. Thanks very much. And Martin, what would your top action be? I'm sure you have lots to address food security in children.
I would be food insecurity in children, I have to say. I think I would look at school meal and breakfast provision in schools. I think if nowhere else, that's where we could get something right, because we got a contained audience. And lots more, I would look at welfare provision and job, but schools I would start in.
Okay, thank you, Martin. And Katie?
I suppose this is a non-answer really to the question. I don't think there is one particular top action. I know that we have a lot of really hard work going on in terms of within schools to ensure that they're healthy school meals and there's the good access to them. I know there's a lot of work that goes into holiday hunger camps, but I think we shouldn't actually need any of those things. You know, we shouldn't have such a reliance on it. And we're talking about what's the best action for children living in food insecurity. I feel the best action would actually be addressing it with their parents, because with their families, the solution should be embedded within an approach that takes account all the policies, so that we're not in 20 years time trying to work out how the children of the children, how we could best help them. We need to help them actually so that they don't grow up with food insecurity and that their children don't experience it. And that's a wide range of policies and changes to be made.
No, thank you, Katie. And Robert?
Yeah, I suppose from our perspective, we look at the costs of minimum standard of living as a whole, of which food is obviously a part. And we find that households with children are particularly vulnerable to inadequate income overall, particularly when they're reliant on social welfare supports or minimum wage employment. And so it's a kind of a double-edged approach then to how do you address that. You address it through more increasing the level of supports, whether that's improving social welfare provision, improving minimum wage, moving towards a living wage, and also addressing costs as a whole. So improving supports with housing costs, improving supports with energy costs, childcare costs, transport, and so on. So it's kind of coming at from both sides, and in that sense then you're addressing food security and food poverty, because really these are, in a lot of cases, these are a symptom of inadequate income. So income adequacy is really paramount from our perspective.
Thank you, Robert. Can I just finally, our time's up. In fact, we've run over, and I would like, first of all, to thank so much our speakers today, Robert and Anne, and Martin and Katie, and also Safe Food, who managed the whole system behind this. So thank you so much. I've really enjoyed it, and I hope our delegates have managed. At one stage, we had 174 participants, which is remarkable, and I want to thank all of our delegates so much for joining us this morning. It's been really useful, and we really appreciate that. So we hope today's presentations, everyone has gained from them, and certainly we have. They will be available online, and Safe Food will manage that on their website, which will be great. It has also been recorded, and the recording will be made available to watch again on the Safe Food events page, and you will be emailed a link to that as soon as it's available. You will also, just to remind you, you will receive an email with a short evaluation. We have an annual event now of the All Island Poverty Network webinar, so we'd really welcome feedback as we continue to build and to try and every year try and come up with new ideas. So any